everyone. Happy Thursday and welcome to OsteoBites. We appreciate your taking time out of your day to spend an hour with us. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are talking with Dr. Nancy Kleber-DeMore about overcoming PD-1 inhibitor resistance with a monoclonal antibody to secreted frizzled-related protein 2 in metastatic osteosarcoma. Thank you so much, Dr. Kleber-DeMore, for joining us on OsteoBites today. We're thrilled to have you. We don't have a panelist from our junior advisory board today for very good reasons. It's because they're all really busy with start of the school year. So we're very happy that they aren't here today for that reason, because they have a really good reason not to be here. A little bit more about our guest. Dr. Kleber-DeMore is a board certified breast surgical oncologist and is the BMW Endowed Chair in Cancer Research at MUSC Health. She obtained her medical degree from Chicago Medical School and completed her residency at Boston University Medical Center, a cancer research fellowship at Harvard Medical School, and fellowship training at Memorial Sloan Kettering Cancer Center. She practiced as a professor of surgery at the University of North Carolina at Chapel Hill for 13 years. She studies angiogenesis as it relates to tumor progression and develops novel angiogenesis inhibitors. She has characterized the role of SFRP2 in angiogenesis and has developed a monoclonal antibody that inhibits tumor growth in preclinical models. And she's now translating this research into the clinic. Welcome, Dr. Kleber-DeMore, and welcome to everyone joining us today. Please feel free to add any questions for Dr. Kleber-DeMore to the Q&A. And before we get started, just have a couple of announcements. We just launched a new monthly newsletter called Connective Issue. It includes info of interest to our osteosarcoma community, including recent news, papers, open clinical trials, job postings even, and info about MIB events and programs. And we spotlight members of our community. And so to make sure you get all this info delivered straight to your inbox, just go to our website and hit the Join Our Community button to subscribe. And there's still time in September to support MIB agents and our programs during Childhood Cancer Awareness Month. You still have time to outrun osteosarcoma with us. You can participate virtually or in person and rack up your miles anytime this month. It's a great activity to raise awareness for pediatric cancer, and we'll put a registration link in the chat. And you can also purchase a gold bow to raise awareness for pediatric cancer and show that you care. There are these beautiful bows that you can put on your mailbox, and we'll put a link in the chat to order a bow. And we would like to thank the sponsor of this episode, BTG Specialty Pharmaceuticals. BTG provides rescue medicines typically used in emergency rooms and intensive care units to treat patients for whom there are limited treatment options. They're dedicated to delivering quality medicines that make a real difference to patients and their families through the development, manufacture, and commercialization of pharmaceutical products. Their current portfolio of antidotes counteracts certain snake venoms and the toxicity associated with some heart and cancer medications. And their drug Varaxase is for high-dose methotrexate toxicity. So Dr. Kleber-DeMore, I'm going to go ahead and turn it over to you. And if you want to go ahead and start sharing your slides, we can get started.
Great. Thank you so much for the opportunity to present my research. I really appreciate the invitation. So I'm going to talk about our work developing a new therapeutic, which is a humanized monoclonal antibody to a protein called secreted frizzle-related protein 2 for osteosarcoma. I do have several disclosures, including several patents, and have co-founded NC Therapeutics and Innova Therapeutics in efforts to translate this work into the clinic. So what I'm going to review with you is a 15-year journey from identification of a novel target for cancer and how the initial focus was on breast cancer and tumor angiogenesis, which was really my scientific field of research, and how this pivoted over the years to include research in osteosarcoma and tumor immunology, and then how we've taken this target and developed a novel therapy for metastatic osteosarcoma and update on the current status. So when I started this research in the mid-2000s, there was a very exciting drug called bevacizumab also known as Avastin, which is a monoclonal antibody to an angiogenesis factor called VEGF. And so angiogenesis is the growth of new blood vessels, and tumors need new blood vessels to grow and metastasize. VEGF stimulates blood vessel growth, and bevacizumab is an antibody that blocks VEGF. And so this became FDA approved for multiple tumors, but it was found in breast cancer that it was initially approved, but then it was found that overall it did not improve overall survival. And so the FDA approval was withdrawn. And so at that time, my thought was, why, if angiogenesis is so important, why, if blocking VEGF doesn't work? And so my hypothesis was that breast tumors must be secreting other angiogenesis factors that continue to stimulate tumor growth even when VEGF is being blocked. And so I thought there's really a critical need for inhibitors of angiogenesis that improve survival for patients whose tumors are not responsive to bevacizumab or that develop resistance. And so the approach that I took is, I'm a surgeon, so I got IRB approval and I took human tumors from the operating room. I think it's really important to discover targets from human tumors rather than mice, because you know that it's actually important in humans. And we know that human blood vessels are very different phenotypically than normal blood vessels, the way that they look. And so I wanted to look at differences in gene expression between tumor blood vessels and normal blood vessels. And I thought maybe that way we could discover some novel genes involved in the angiogenesis. So the approach that I took was I took human tumors, I sectioned them, I stained them for a stain for blood vessels, and under the microscope, developed a technique to do laser capture microdissection of these blood vessels. And so you can see the before, this is where we did the microdissection, and then we have our sample. And our sample was in an Eppendorf tube with RNA extraction buffer. We extracted the RNA and we were able to do microarrays and compare differences in gene expression between tumor vessels and normal vessels. So this was done again in the mid-2000s, and we found 55 genes that had very high overexpression in the tumor vessels. And I went through those genes and I focused on genes that, number one, had never been described to be involved in angiogenesis, and that encoded proteins that were either on the membrane or secreted proteins, because those would be the easiest druggable target. And so the gene that was most interesting me was called secreted frizzle related protein 2. And this was highly overexpressed in the tumor vessels with very low expression in the normal blood vessels. And it had never been implicated in angiogenesis. So we spent decades really looking at what is the mechanism, how does SFRP2 stimulate angiogenesis? And what we found is that this is a picture of kind of a tumor and some of its microenvironment. Here's the tumor cells, here's the malignant blood vessels, and this is a blow-up of an endothelial cell. So what happens is SFRP2 binds to a receptor called frizzled 5. And once that happens, it stimulates a protein called calcineurin to go into the nucleus, and this activates a transcription factor called NFAT-C3. And NFAT-C3 stimulates the angiogenesis. So we elucidated this molecular mechanism of how it stimulates angiogenesis in blood vessels. But what we found, and this is what really makes this protein very interesting, even more so than other proteins involved in angiogenesis like VEGF, is that we thought this was just going to be involved in angiogenesis, but we found that SFRP2 actually acts directly on the tumor cell. And it turns out that in the tumors, it also binds to frizzled 5 and activates NFAT-C3. And when it does that, it decreases tumor apoptosis, so it helps the tumor to survive. It increases tumor migration. It increases tumor metastasis. So there's actually a direct role on the tumor itself and in angiogenesis. And our recent finding that I'll go into a bit more detail later is that it actually does the same thing on activated T cells in the tumor microenvironment. And so what we have found is that SFRP2 actually causes T cell exhaustion by increasing exhaustion markers like PD-1 and CD38. And I'm going to go into detail why this is very important. So this unifying role that SFRP2 binds to Frizzled-5 on the tumor, on activated T cells, and on tumor endothelial cells, and through this mechanism of activating NFAT, acts on all these different cell types. So the reason why other people had not recognized that SFRP2 was important in tumor growth was because SFRP2 belongs to a family of proteins, and including SFRP1. And SFRP1 was known to be a tumor suppressor. So the way that SFRP1 worked is it worked through the beta-catenin pathway. So Winds normally bind to frizzled proteins and activate beta-catenin. And when beta-catenin is activated, that causes tumor growth. And what SFRP1 does is it binds to Wnt, making Wnt not able to bind to frizzled, so it blocks this pathway. So the SFRP family was thought to be inhibitors of tumor growth. And this is why people really didn't know that SFRP2 was actually a stimulator of tumor growth. There was no data, but it was assumed that it was a tumor suppressor. And that's actually what got me so interested. When I saw SFRP2 on my gene list as being highly overexpressed, and I kind of read about it and it said it's a tumor suppressor, I said, why would a tumor suppressor be overexpressed? And it was that dichotomy that got me interested. What we found was that SFRP2 does not act through beta-catenin. So when we silenced beta-catenin from our endothelial cells, SFRP2 continued to stimulate angiogenesis. And that's what actually made us start to look at what we call non-canonical Wnt pathways. And that's where we found that SFRP2 binds to frizzled and activates NFAT. And here's just some of that data. So these are endothelial cells, and this is a Western blot, and without SFRP2, NFAT's very low. When we add SFRP2, NFAT's very high. And we see that not only in the endothelial cells, but we see that in breast cancer cells, and we see that also in angiosarcoma cells. And when we add our monoclonal antibody, NFAT goes down in the endothelial cells, the breast cancer cells, and the angiosarcoma cells. So that's really what, when we found this, there was actually, a lot of people in the literature that, were kind of confused by this and maybe didn't believe us. And so what's really nice is that our findings have been widely validated by the research community over the years by subsequent groups. So SFRP2 has shown to promote tumor growth in colorectal cancer, renal cell carcinoma, multiple myeloma, lung cancer, pancreatic cancer, prostate cancer, osteosarcoma, which I'm going to talk about today, and other sarcomas. And there was a paper from a group from Johns Hopkins recently published in Nature that showed that it's very important in melanoma. So initially we had this initial discovery, and then ultimately this did become widely accepted in the field. And when we look at Tcga databases that look at, so for those who might not know what Tcga is, it's the Cancer Genome Atlas, where these are databases of sequencing a very large number of human tumors. And so you can take your gene of interest and you can look at its expression in a large number of tumors. And we found that it was overexpressed in many tumors. And I'm highlighting here sarcoma, breast, and pancreas, which are really our main focus right now in the lab. And you can also, in the Tcga, in these human cancers, you can do Kaplan-Meier curves to look at survival, and you can dichotomize your tumors to those that have low expression and high expression. So if you see here for pancreatic cancer, the blue line is a survival for patients who have low expression for SFRP2, and the red line is those that have high expression. Pancreatic cancer is very lethal, and this is absolutely amazing to me that you can have patients with really good survival if they have low SFRP2 expression. And so it's shown that it is prognostic for many human tumors. The TCGA, it's hard to get a subgroup for sarcomas, and I couldn't find one specifically for osteosarcoma. And this is just some work that we did in pancreatic cancer. We took human pancreatic tumors and we did Western blot looking at the pancreatic cancer and the adjacent normal tissue. And we found that SFRP2 was overexpressed in the tumor compared to the normal tissue. So these are all matched samples. And then we also dichotomized in our own group of patients and saw the same thing. Low SFRP2 expression had better survival than high SFRP2 expression. And I always like to show other people's work because that really, I think, validates what we found. So there was a group from China that looked at the plasma levels of SFRP2 in patients with breast cancer. So they took 274 patients with breast cancer and 147 healthy controls, and they found that SFRP2 was elevated in patients with breast cancer. And then they looked just at the patients with breast cancer and they dichotomized to a low and a high expression. And they found that, and they did a Kaplan-Meier curve, and they found that if you had a lower SFRP2 expression, you did have a better survival. And they found that on multivariate analysis, SFRP2 was an independent prognostic factor for poor prognosis. So based on this data, my lab went ahead and we first developed a mouse monoclonal antibody to SFRP2, and then we went and we humanized the antibody. And I just want to briefly go through the strategy that I took. And I think this strategy is why we have an antibody that works so well. So what we did initially was we looked at the amino acid sequence of SFRP2, and we looked at those that were unique to SFRP2 and were highly immunogenic. And so we made polyclonal antibodies. And what we did is what a lot of people do is they will, so you have multiple clones. Let's say you have 80 clones, and people will look at its at the ELISA, at its ability to bind to SFRP2 in a plate, and they'll pick the antibody that has the best binding capability. But what we did in addition to that is we found angiosarcoma cells have extremely high levels of SFRP2 expression, and we were able to plate these cells in a tube assay. It takes about 4 hours, and we take our 80 clones and we see which one has the best activity in vitro at blocking tube formation. So we went ahead and we did all of our subsequent cloning, not just based on what had the highest binding activity, but actually what was the most effective in cell culture. And because of this, we generated a very active antibody. And we did some studies and we found that the antibody was non-immunogenic. The other thing that I think is really important about this antibody is, we discovered this in that it was very highly expressed in tumor vessels and not normal vessels. If something's going to be a good target, you don't want it to be expressed highly in normal tissue because then you can have a lot of toxicity. So this is an experiment where we took the SFRP2 antibody, and one of my colleagues at UNC is a bioengineer, and he developed a fluorescently labeled ultrasound contrast agent. And we were able to take our antibody and conjugate it to his fluorescently labeled ultrasound contrast agent. And so what we did is we injected an angiosarcoma on the back of a mouse and let it grow till it was about 1 centimeter. And then we had our control contrast agent and our SFRP2 antibody contrast agent. So immediately we inject our contrast agent IV. And everything that turns green here are blood vessels, okay? So this is where all the blood vessels are. And then after 10 minutes, almost all of the contrast agent washes out, and this is just the outline of where the tumor is. But in the SFRP targeted contrast agent, after 10 minutes, it's washed out of most of the normal surrounding vessels, but it's highly concentrated in the tumor vessels. And this is showing in a mouse that really SFRP2 is binding to tumor vessels and very little binding to normal vessels. We also looked at the kidneys and found that it didn't bind to the normal vessels in the kidney. So this is really specific for tumor. So we then went ahead and started some mouse models to see how effective this was. And again, I started, I was initially starting in breast cancer. So this is a very aggressive, what we call metaplastic triple negative breast cancer. Triple negative breast cancers are much more aggressive. There's not many therapeutic options other than chemotherapy. And the metaplastic actually act more like sarcomas. And this cell line's resistant to doxorubicin. And so we started treatment when the tumors were about a cubic millimeter. So they were already established. And then we went over close to 60 days, and these are our control mice. But our mice treated with the antibody had a very large inhibition of tumor growth. We saw no toxicity in the 60 days that they were treated. We then did another study. So this was at a dose of 4 mg per kg. We then did a study looking at 5 times this dose at 20 mg per kg. And we treated for 3 weeks, and we wanted to do a little toxicology study. We resected the kidneys and the liver, and pathologically, there were no changes in the kidneys or the liver under the microscope. The mice did not lose weight. They appeared healthy. And so we have not seen any signs of toxicity at this point in our mouse models. So we knew that it was effective. And when we resected the tumors and we looked under the microscope, we also looked at angiosarcoma, and it inhibited that too. We looked at tumor apoptosis. So what apoptosis is that's programmed cell death. So when the cells die, and these are the controls. And when we treat both the breast cancer and the angiosarcoma, the brown cells here are the apoptotic cells. And you can see there's a large increase in the tumor cell death. And this is showing, again, as I mentioned, what we saw before is that this not only is acting on the blood vessels, but it's directly acting on the tumor cells themselves to cause apoptosis, which causes the tumors to die. So now I'm going to talk to you about how I became interested in osteosarcoma. So there's 2 things that happened. One is that there was this really fantastic paper by Jason Eustein, who is a pediatric oncologist. This was done when he was at Texas Children's Hospital at Baylor. He recently moved to Emory. And he published this paper that showed that SFRP2 is very important in osteosarcoma metastasis. He found that within localized human and mouse osteosarcoma, when he transfected these cells with SFRP2, it greatly increased their migration and their invasive ability and their metastatic ability. And the opposite, when they knocked down SFRP2, it inhibited tumor growth. And this is a lung metastasis in osteosarcoma cells without SFRP2. And you can see when you overexpress SFRP2, there's really an explosion of metastatic growth. And he found that it's really the lung metastases that have the higher expression. This is human tumors, non-metastatic and metastatic. And so this is something that really caught my eye. Unfortunately, around this time, my daughter's best friend, Weston, who he was her very good friend since kindergarten. They played together, they went to school together, and they were really best friends. And when he was 15, he developed osteosarcoma, and he went through very extensive treatment, surgery, and every time he went through a round of extensive treatment, his scan showed that things had progressed, and eventually he passed away. And I know that there are many of you that probably have the same experience, and it really was one of the most devastating experiences for my family. And then my daughter, about 6 months later, developed back pain, and she said maybe it's a tumor. And of course, you're thinking, no, it can't be a tumor. You know, you're thinking this because of Weston. And MRI found that she did have a tumor in her spine. And at that time, it turned out, fortunately, to be a benign bone tumor called an osteoid osteoma, but the doctors did tell us it was possibly an osteosarcoma. And so, you know, we really had that great scare. So I think that you can see why osteosarcoma research has really become a passion of mine, because as you all know, there haven't been new treatments in 20 to 30 years, and we really need new agents. And so, you know, it was hard for me to see him go through all this when I, you know, read Dr. Houston's paper, and I thought, we have this antibody in the lab and maybe it's going to work. And so maybe someday it'll work for someone else. So that is why I've really focused on osteosarcoma. And so Dr. Houston was very kind. He's been a great collaborator. He shared his genetically engineered mouse models with us. The RF420 and RF577. These are two mouse models of osteosarcoma that he created. And initially we tested them for apoptosis and cell culture. And we found that when we added the antibody, we had a large increase in apoptosis. And so we then went ahead and used his model in a metastatic model of osteosarcoma. So in this model, to get metastatic disease, we injected the osteosarcoma cells through the tail vein. And we did studies, and we found after about a week, when we looked under the microscope, we had sacrificed some mice to look at the model. We found that lung metastases were established. So when at about day 10, we started treating with either our control or with our SFRP2 antibody. And then after 3 weeks, we sacrificed the mice, and we were able to count on the surface the number of lung metastases. And you can see these lung metastases in the control, which are really very clean in the SFRP2 treated lungs. And we also sectioned them under the microscope and counted the number of micrometastases. And we found, as monotherapy, the antibody was effective at inhibiting tumor metastasis, and we didn't see any signs of toxicity. And we wanted to look at the mechanism of how this was happening. And since these were immunocompetent mice, we had never looked, no one had ever looked at the role of SFRP2 in tumor immunology before. And since tumor immunology, we've all realized is so important in cancer, we wanted to look at that. So I started collaborating with the tumor immunologist, Shekhar Mehrotra. And what he did is he isolated the tumors from the lungs. And from that, he isolated just the tumor infiltrating lymphocytes. And then we also took the spleen, and we isolated the T cells from the spleen and the tumor infiltrating lymphocytes. And then Dr. Mehrotra did flow cytometry for a number of different important T cell exhaustion markers. And what we found is the one that had the most effect, we found a reduction in a protein called CD38. And I'll talk about why CD38 is important in a minute. But it was reduced both in the T cells from the spleens and from the tumor infiltrating lymphocytes. We also did see a reduction in PD-1 as well. We didn't see a reduction in other exhaustion markers. And so that's where we started to realize that, that the antibody is actually affecting the tumor infiltrating lymphocytes, and this could be an important mechanism. So we actually went back, we went from the mice, we then went back into the lab, and we looked to see what is the role of SFRP2 on T cells. No one had ever looked at that before in vitro. So we took T cells and we treated them with and without SFRP2. And then we looked by PCR at CD38 levels and PD-1 levels. And we found that when we added SFRP2, the T cells increased mRNA of both CD38 and PD-1. When you increase PD-1 in a T cell, it makes a T cell exhausted. It makes a T cell so it won't now attack the tumor. That's why increasing PD-1, if SFRP2 increases PD-1, it's going to cause the tumor to be resistant to the normal T cells. And then we showed at a protein level, we did Westerns and we added SFRP2, and CD38 was increased by the Western as well as PD-1. And I won't go through the rest of that. So, so the reason that this is important with CD38 is that CD38 has been shown that there are some tumors that are resistant to PD-1 inhibitors. And you may know that immunotherapy is active in many, many different tumors, particularly in melanoma and lung cancer with PD-1 inhibitors. There was a phase 2 study in osteosarcoma, and unfortunately, it was a negative trial. PD-1 inhibitors did not work in patients with osteosarcoma. And my colleague, Dr. Mehrotra, has done a lot of research that showed that in other tumor types, one reason that tumors are resistant to PD-1 inhibitors is through an elevation of this protein called CD38. And there had been studies that showed that when you reduce CD38 levels, all of a sudden PD-1 inhibitors become effective. And Darzalex is a monoclonal antibody to CD38. And it's presently used in multiple myeloma. It's very effective in multiple myeloma. But the problem with Darzalex is that CD38 is not only expressed on tumor cells and tumor infiltrating lymphocytes, it's expressed on normal hematopoietic cells, on all these normal cells. And so one of the side effects of giving an antibody to CD38 is you get a lot of neutropenia and sepsis. And so they did studies where they combined an antibody to CD38 and a PD-1 inhibitor, thinking maybe you would get an increased effect. And the clinical trials were actually shut down because there are actually more deaths in the combination group. And so one of our thoughts is that, you know, one of the problems again with CD38, if you're using a CD38 antibody, you're shutting down CD38 throughout the body. Whereas for SFRP2, this is looking at a publicly available database. SFRP2 is very low expression on normal hematopoietic cells. And so our hypothesis is you can reduce CD38 in the tumor infiltrating lymphocytes and in the tumors, but not in the normal cells. And so therefore, if you combine an antibody to SFRP2, you could shut down the CD38 in the tumor microenvironment and combine it with a PD-1 inhibitor and maybe make that PD-1 inhibitor active without causing the toxicity. And so that's where we got the idea to start combination therapy with a PD-1 inhibitor. And so we went back to our mouse models, and this again is the mouse osteosarcoma. We injected the mice with our osteosarcoma cells. After 3 weeks, we resected the tumor. The control had about 100 macrometastasis. The PD-1 inhibitor was not effective. The SFRP2 antibody did work by itself, but the combination was even better. And so this is where we really think the value of the antibody is going to be, because most drugs do not really work as monotherapy, but you want to find a mechanistic rationale. And we think that this could really be something that's very important. Maybe we could make osteosarcoma sensitive to PD-1 inhibitors by giving the SFRP2 antibody. And in these mice, over the 3 weeks, we didn't see any signs of toxicity. We looked in a second cell line that Dr. Justine gave us and found the same effect, that the combination was really the best, and no weight loss in these studies. Now, I showed you some experiments before that people have looked at, particularly the study from China, where they looked and they found that SFRP2 was elevated in the serum of patients with breast cancer. So we've started to look to see what about in our mouse models and what about with treatment. So we looked at mice without tumors compared to mice with osteosarcoma metastasis. And we found that in the serum of the mice with tumors, SFRP2 levels were higher. And then when we treated the mice, we found that SFRP2 levels went down. And we don't understand why it went down with a PD-1 inhibitor, but you don't always understand all of your results. But the reason that this is important is we are, when we go to clinical trial, we always want to see if we can find correlative markers for response. And so we are going to be doing SFRP2 ELISAs at the beginning of treatment and during treatment, and then we can see, does the SFRP2 level, does that correlate with response to treatment? And, you know, in the future, if it did, maybe you could monitor SFRP2 levels to see if the tumor came back. So that's why we're interested in developing this, because it's always good to have correlative markers of response. So in review, we found that the SFRP2 antibody inhibits multiple tumor types in both human tumors, in immunodeficient mice, in mouse tumors, in immunocompetent mice. It inhibits primary breast cancer. I didn't show you the data, but also primary angiosarcoma and metastatic osteosarcoma. And its mechanism is that the antibody binds to SFRP2 and blocks this non-canonical Wnt pathway. And so we're really blocking angiogenesis. We're blocking the T cells from increasing all of these exhaustion markers, and we're increasing tumor apoptosis. So I will go to what we want to do. So I have formed a startup company or a biotech company called Nova Therapeutics. And the reason for this is that it is extremely expensive to manufacture a monoclonal antibody. And to do these studies is really outside kind of the normal NIH funding mechanism. And so we are trying to raise funds now so that we can do this clinical translation. And so once we have the funding, then we're going to go ahead with a GMP manufacturing of the antibody. And then we will do our preclinical toxicology studies. And we want to do our initial phase 1 study. We plan to do both adults and pediatrics so that we can get the pediatric dose. It's going to include solid tumors, including breast and pancreatic cancer. We specifically are going to be doing a pediatric osteosarcoma arm so that we can get that pediatric dose. And then we hope to go with that into a phase 2 study and also do some combination studies with PD-1 inhibitors. The FDA has granted the antibody rare pediatric disease and orphan disease designation, and that allows for expedited review. So thank you so much for giving me the opportunity to share what we're doing, and I'm happy to answer any questions.
Wow, thank you. That was an amazing presentation. Thank you so much. And thank you also for sharing your story and kind of your unfortunate personal connection to osteosarcoma. But it's, and also thank you to Dr. Justine. So Dr. Justine is also actually one of our Outsmarting 2022 grant recipients. And I know he is an amazing collaborator, and his mouse models certainly get around. So it's also great to see how they've helped inform your work.
Yes, absolutely. Yeah.
So everyone, please feel free to add any questions you have to the Q&A, but I maybe wanted to get started with a couple of simple questions about SFRP2. I'm curious, like, is it a standard IHC test? Like, could someone just at their institution get an IHC test for SFRP2? Or? No,
it's not a CLIA approved test yet. Okay. I think so that, you know, as we progress into the clinic, so what we don't know is, do levels of SFRP2 expression correlate with response? Is it like HER2 new and breast cancer with Herceptin? And so we're going to embed into these studies a lot of correlative studies. So we will look by IHC and we'll develop a scoring system of 1+, 2+, and 3+. We'll look at the tumor, we'll look at the serum level. And then other things I think that we'll look at is, in monitoring is we can look at tumor apoptosis, we can look at tumor angiogenesis. And so we really are going to embed these studies very heavily with correlative markers, so that, maybe there are certain subgroups that will respond, if not all patients respond. Can we identify what would be? So these will all be tests. And then if it is, and then that would be something that we would move forward to try to develop a CLIA approved test.
Mm-hmm. I wonder, so is there a difference between, understanding it as a correlative response, but is there enough evidence based on some of the, information you presented to think of it though as like a marker for risk stratification?
So in breast cancer, so I think that there, in other cancers, so in osteosarcoma, there isn't. In other cancers, we certainly have seen with the TCGA level that in many, many tumors, expression of SFRP2 is prognostic for survival. So we saw that with pancreas, we saw it with breast, we see it with bladder cancer, a number of different cancers. We have to get enough osteosarcoma samples, and I think that would be a really good project, would be to get enough osteosarcoma samples and do Westerns or do an ELISA and see if it does correlate with response. I really would like to do that. And we actually, there are commercially available ELISAs. We have found that they are not always consistent lot to lot. And so for us, we're developing an ELISA with our humanized antibody, which is from, we have antibody a very large amount, so it's from one lot. So we, that is something that we do want to look at for osteosarcoma. It does level correlate with survival.
Mm-hmm.
I haven't done that yet.
It's an interesting area because I don't think, we actually had Dr. Amanda Marinoff from UCSF she talked about MYC, and I think there's a greater understanding of MYC, for example, as a marker for risk stratification. But it's just interesting as we're learning more, it just seems like you might be able to kind of identify.
I think you brought out a very important point. I think that is something that we definitely need to do, is to see. I wouldn't be surprised if it is, just because it seems to correlate with survival in other tumors, but we definitely need to look at that. And then, what we don't know is, because it seems to be very important in metastatic disease. So the question is, does SFRP2 level in the primary, does that correlate with survival?
Right.
I don't know,
Yeah.
So there's all these, a lot of research that we need to do to understand that.
And so it's interesting. So if I was following this correctly, so you initially identified it in the tumor blood vessels.
Yes.
But then realized that it was also present in just the tumor cells.
Yes.
And then you saw that it was also present in plasma, right? So then my other question is, like, in terms of, monitoring related to risk stratification and monitoring is, being able to monitor this in liquid biopsy as well, both either for risk stratification or just monitoring for, early signs of a relapse or recurrence.
That's what we want to look at in our clinical trials. Absolutely.
Yeah.
That's very important. We don't have that information yet, but yes, we want to look at that.
Yeah. And then what are your, because, looking at some of the graphs too, it looks like, especially the combination does a good job at inhibiting growth, but not necessarily, and it would reduce like tumor size, but it's not necessarily totally eradicating, right? Mm-hmm. And so, it seems like with some of these, like both targeted therapies and perhaps this with more of an immunotherapy, that it can be more effective when there is minimal disease, less visible disease, less bulky disease. Mm-hmm. And so, in a dream world, you could get to a point where there is a risk stratification. So you could say, okay, this, we know there's high risk for recurrence. And so what are your thoughts in for this? And I mean, even in general for monoclonal antibodies like this, for using it more as maintenance disease. So after you've, surgically resected, all that stuff.
So a couple things.
Yeah.
In terms of, so what the Mauro Vitas Foundation is funding our research is, what we really need to do is really combine this drug with a lot of different agents to see what is the most active. And so that's what we're doing with the grant that they gave us. So we're combining with the PD-1, the antibody, with doxorubicin, with other anti-angiogenic agents. And so the timing of their grant is really great because it's going to be at least a year before we get into a phase 1 trial. So it's going to be at least, over 2 years until we get to a phase 2. So during this time, we can do all the preclinical works on multiple different combinations so that when we want to do a phase 2 and combine therapy, we've kind of laid the groundwork for what is the best combination therapy, number one. Number two, I think that it may be that a really great place would be for adjuvant therapy. So in someone without metastasis and resection of the primary tumor, and then going on maintenance adjuvant therapy. We certainly would love to look into that. Clinical trials are always done with, especially this will be a first in human trial. And so you have to do your toxicity and all that and your PK studies. And so that's always, your first studies are always done in patients with metastatic disease. But once we understand the best dose and the safety of it, then hopefully in the future we could do adjuvant therapy trials and go earlier in preventing micrometastatic disease from growing. And especially if it's not toxic, that would be a wonderful thing, to improve survival. So that would certainly be something that we'd be looking at in the future.
So that's interesting. So you are looking at different drug combos, even with kind of like first line osteo chemos, like MAP or IE or.
Well, so in this grant, right now we have 3 combinations that we're going to be trying.
Okay.
So 2 are target agents and 1 is doxorubicin, and then we'll kind of get through that. So that'll be that we've tested 4, and then also once we get more funding, then we'll look at other combinations as well. But I think that's really important while we have this time, a couple of years before we get to a combination trial, really to look at as many combinations as we can. And we try to be very mechanistically based in our combination. That's why we start with the PD-1 inhibitor, because we know CD38, but, also, it makes sense to look at other angiogenesis inhibitors and to give it with chemotherapy and see what we get.
Yeah. I was going to say that it's hard, I guess, in trials, because normally in that setting you are, trying to monitor, right? So you kind of need some sort of disease to be able to see what the impact is. So it's probably hard to do a trial with someone that doesn't have any measurable disease.
So typically with clinical trials, it's, the first trials are really in the metastatic setting.
Yeah.
And then if a drug shows efficacy and safety in the metastatic setting, then you move to kind of a high risk non-metastatic setting. And so those studies really come later after you've shown it's safe and effective. Right.
Yeah. But it just seems like, particularly for this, because it seems like you might get greater efficacy in that setting, right, where there is minimal disease. So
I think you're right. Yeah, yes. Yeah, it's I think that, and I think we certainly we'll be working closely with the FDA in terms of our trial design, and because this is a rare pediatric disease, and because there isn't any therapy, that sometimes things can be expedited. So.
Yeah. And I'm curious about resistance issues. So I feel like sometimes in targeted therapies, resistance is an issue, right? Because you can block a pathway, but eventually, the cancer will kind of find another way. And so with immunotherapies, and particularly for these monoclonal antibodies, can you talk a little bit about if there are resistance issues, and if so, what that looks like? Because
Well,
I kind of sometimes think of it, since it's your immune system, that you're basically just kind of helping prime the immune system to do what it's supposed to do. But
right. So that's so for the PD-1 inhibitors, one of the mechanisms of resistance is elevated CD38. And that's where we think that, by reducing CD38 with the SFRP2 antibody, we can overcome resistance. What will we find will be, resistance to SFRP2 therapy? We haven't gone that far yet. I think everything develops resistance eventually. So we're not there yet with that.
yeah. Well, this was super interesting, and I so appreciate your taking the time to share with us today, and can't wait to hear more about progress on the trial. It's exciting that you have the orphan drug designation for sure, because I'm sure that will kind of accelerate progress on this.
Yeah.
And
thank you so much for inviting me. I really appreciate it.
Yeah, and so great for the grant from the Myelofibrosis Trust to support this work.
Yeah. Really appreciate that. Yep.
Yeah. So thank you so much for joining us today and for making it better for all really cancer patients, but particularly osteosarcoma patients everywhere. More information on this and all OsteoBites can be found on YouTube, on our website at mibagents.org, and at your favorite podcast place. And next week is the third Thursday of the month. So instead of OsteoBites, we're going to be dropping another episode of Osteo, which is our AYA podcast, where our junior advisory board members spill the tea on all things osteosarcoma from an AYA perspective. Camille, Vicky, and Shannon are going to be discussing dating and intimacy as an AYA cancer patient with Lauren Broshek, who is an oncology certified licensed clinical social worker at Innova Life with Cancer. It's going to drop next Thursday, the 22nd. So keep an eye out for that. But just a strong disclaimer that the content of this episode definitely skews more young adult than adolescent. So keep that in mind. And then we are going to return with OsteoBites on Thursday, October 6th, when we talk to Dr. Sam Volchenboom. He's the director of the Pediatric Cancer Data Commons at the University of Chicago. And he'll be talking to us about transforming the way researchers share data, lessons from the Pediatric Cancer Data Commons. You can find our OsteoBites lineup for the rest of the year on our website. And if you have any ideas for future topics you'd like to hear about, just email us at events@mibagents.org. Thank you again to Dr. Clever DeMore for spending an hour with us today, and to our sponsor, BTG Specialty Pharmaceuticals. And thank you for joining us today on OsteoBites, and we hope to see you when we return on October 6th.